Go to the next talk, Dr. Sushmita. So, ab interno bleb revision. So, sometime is we can actually do from inside of the eye also for the failed bleb. So, I think Dr. Sushmita is going to talk us through that.
And good morning. And at the outset, I thank Professor Panda for the opportunity to be a part of this. So we'll be talking of something which is ab interno, akin to needling, which Faisal just showed us, except that we go from inside. And ab interno is the flavor of the season for glaucoma. So needling and revision is also there. So failed trab with high IOP, the options, of course, are needling, bleb revision, which could be ab externo, but it could be ab interno as well. Of course, you could do an additional trabeculectomy, a drainage device, or cyclophotocoagulation. So you'd like to revise something which has been done first before going into second surgery. How do we decide? So we found a couple of years ago, we did a thesis, and it was a clinical utility of the UBM to assess the likelihood of needle revision success. And the question was, why is it that some needlings work and why is it that others fail? And is there some way to predict which is the one which is likely to work and spare them the trauma of needling done? And when we started doing UBMs of the blebs, we realized that there was some in which you could see the fluid right up till there, but it was all scarred subtenons. And there was some in which you could not see that at all. So we termed these a scleral root patent or a scleral root occluded. And intuitively, it's common sense that if you have an occluded scleral root, then simply doing a needling in the subtenon space is not going to work because fluid is not going to go out. Whereas if the block is beyond the subscleral space, so if you have a subscleral or a scleral root patent, those are the ones where needling would work. So we published this a couple of years ago and used this pretty routinely. And the SRO blebs were always likely to need a revision with lifting of the scarred bleb, but the scleral root patent ones, and you can see that's the one that is patent here, once you just do a subtenons needling, you have fluid under the subtenon space as well. And whereas the SRO bleb, nothing much happened. So this was an occluded and nothing much happened even after the needling, and we had to do a revision. So coming on to that, then ab interno revision is recently described. It's the external is more invasive and requires conjunctival dissection, whereas here it's less invasive, it's more controlled, and it's a little more predictable. So it's come up, there is a novel Grover-Feldman spatula. It's available. It's a nice curved spatula. It's long. It's at least 15 millimeters because you need to go across the eye, across the bleb, and then do an ab interno needling. The distal end is about 20 millimeters and 0.5 millimeters wide, and the tip is flat, it's blunted, it's anteriorly beveled, and it allows blunt scar tissue dissection without being sharp. So you're not likely to go through the conjunctiva if you're careful and you're controlled. So the principle of the technique is first a gonioscopy. You need to have an open sclerostomy. That's pretty obvious because this is going to go through this sclerostomy under the scleral flap and is going to open up the bleb. That's the idea. So what we do is principally an inferior conjunctival paracentesis. Put in a bit of viscoelastic, insert the GFS spatula into the sclerostomy site under direct visualization of a gonio lens. And you can see here it is inside the sclerostomy. And once it's in, then you remove your gonioscope and then you move it side to side. So there's a small clip which I'll show, a representative case of a 54-year-old POAG, failed trab, scarred bleb, patent sclerostomy. Typical patient to do, now we don't do the UBM and figure out which to do a needle revision. We just use the spatula, do an ab interno, do not open up the conjunctiva or poke in any needles, no more dissection of the blood vessels and all that, and we just do an ab interno. So this is what it looks like. So this is what the spatula is. It's 20 millimeters, and this is the tip. So this is topical anesthesia. If they're not too cooperative, you can give a block as well, but this was a nice cooperative person. I like to use pilocarpine to protect the lens as much as possible, even though it's pseudophakic. So as usual, a cohesive viscoelastic on the surface of the eye. And this is an indirect gonio lens. You can't use a direct lens because you can't tilt the head upwards. So we use an indirect. So we go across and there you are, the indirect gonial lens. So it's a little bit of a learning to learn to put your spatula into the sclerostomy with an indirect gonial lens, because you're working against what you're seeing and it's a mirror image. But once you're in the sclerostomy, you can see that it's entered. You can remove the gonial lens and then go on, and then it's really simple. So this is the only tricky part, to get your spatula into the sclerostomy. And once it's in, then that's it. Then we just gently use a bud, and you can see this gentle to and fro movements, and this we are under the scleral flap. And in a little while, you'll see that we have traversed the scleral flap and we've actually gone into the subconjunctival space as well. And that's what happens when you see the blue tip of the cannula. You see the blue tip there? There you are. So you can now start seeing the blue tip of here you are. Can you see this under the subconjunctival space? So now you're under that as well. So you've traversed the subscleral space, you've gone into the subconjunctival space now, and gently, and you can see there's no bleeding because it's completely blunt, but it's gentle, and there you are. So there is the tip of the thing seen, which tells me that I've traversed the subscleral flap. I've gone, and once you're in the subconjunctival space, then it's easy. Then you get a little more. So the important thing is to go straight up there and not go side by until you reach the subconjunctival space. And then when you've opened it up, then you can sweep across really, and you can open up this bleb nicely. So I'll just show you the end, which is, where is it? Yeah, so at the end, all you need to do is, when you remove it, we just hydrate it, and when we hydrate it, you'll actually see the bleb forming quite well. I don't know why this isn't moving. ये video नहीं चल रहा suddenly भैया. It just shut. It's hung. Okay. क्या करूँ? Close. नहीं, hang हो गया. Close. I'm so sorry. I just wanted to show you that at the end, all you need to do is hydrate it, and the bleb just forms when it hydrates, and then you know that you're probably in. We didn't, I mean, by the time you just do that, it just keeps coming out. You can. हाँ, ये था वीडियो. इसका एंड दिखा दो बस. वो ना बीच में बंद हो गया अपने आप. I don't know why. एंड कहाँ गया? हाँ, ये. Yeah. So there is a bit of bleeding there. So I just wanted to show that sometimes happens because it is sort of blind. But then you put in an air bubble, and next morning usually nothing happens and it's fine. So this is what he looks like. So this was absolutely flat, and here's all the fluid there. It's 18 millimeters he was pre-op, and post-op day 7 he's about 7 mm off drugs. And we sort of, over 6 months' time, he looked very good, and this is what the blebs remain as. So we're quite surprised that this actually happened. So we looked at them. We use the AIOC as well now. You can actually see, now this is just a gimmick. You might as well do your gonioscopy and see the sclerostomy. This is just to show that you can use a sweat source AIOC to show you your sclerostomy. So that's the sclerostomy of this bleb. And you can see this bleb, it's completely occluded, and no amount of needling is going to open this up. So this is a classical bleb in which I'd like to do an ab interno. And when we did that, you can see this has opened up. So this opens up the scleral flap from beneath it, and there's fluid under the, so this is this bleb, which becomes this with all this fluid which is under the scleral flap as well as the tenons. So this is now much easier than doing a UBM, since we've acquired the cassia and we are lucky. So the early experience is encouraging. Quickly, I'll share that in the next minute or so. We looked at patients with a minimum of 6 months follow-up, but some of them have a year's follow-up. It's about 15 eyes now. And the mean age was all around 60 years. And the mean age of the bleb was about 5 years, but they range from 6 months to 17 years. And so the complete success of less than 18 millimeters without drugs was about 40%, but 60% with up to 2 topical medications. So if 2/3 of our patients can do without an ab externo, needling, revision, second surgeries, for me that's good. And the failures we had was zero, which was good. Nobody had hypotony, nobody had serious complications warranting any other surgery. These are the graphs of the IOP change, but more importantly, the anti-glaucoma medication change. So from 3 drugs or 3.7 drugs, which is almost 4 drugs, down to 1 drug or so, for me that was good. So if you can just get back to that. We had transient hyphemas, of course, you see it on table. We had one shallow anterior chamber and one conjunctival buttonhole and microleak while we were still learning not to be so aggressive. So now we don't see them too well. So thank you. It's something that's worth exploring, and we're very happy with the results and hope we come out with 1 year and 2 year follow-up soon. Thank you.
Thank you, Dr. Sushmita. I think before I go to my presentation next, I think just a quick question: how do you kind of choose which bleb would be needled externally and which bleb would be needled internally?
So frankly, sir, I've stopped the needling externally because this is so much easier to just take them into the OR. But definitely on the ASOCT, if there is a good scleral root patent, then you might have a case for doing a subtenons needling. But this is lesser invasive than a subtenons needling also, because we do go into, and it's easier if it's not fibrosed, then it just goes straight into the subtenon space and it's easier to do it from inside.